Thank you for those in the room for taking time out of your busy day. And for those people online, thank you also for taking time out of your busy day. This presentation is being recorded, and we really value your feedback. So there's QR codes on the tables, and there will be one for the Zoom folks as well. And then kind of a little advance notice plug. Next week, November 12th, is our lecture titled Finding Meaning in Medicine. And I think that will be really, especially in November when we're a season of gratitude. And that was one of our more popular ones last year meetings, and the speakers have worked further to expand their thoughts about how we can find that meaning. We're thrilled to have Dr. Elizabeth Kudron join us today, presenting on the Colorado Center for Personalized Medicine Biobank. She'll cover how it advances personalized medicine and the current process for returning genomic results. So a little bit about Dr. Kudron. She's an associate professor of biomedical informatics and pediatrics at the UC Anschutz. She earned her MD from the University of New Mexico and completed her pediatrics residency at Nationwide Children's. And after several years in private practice, she earned a master's degree in public health from the University of Colorado and found her passion for personalized medicine. Since 2018, she has served as Associate Director for Program Education at the Colorado Center for Personalized Medicine and co-directs CU's Personalized and Genomic Medicine Graduate Certificate Program. We were chatting a little bit before the presentation about how as two generalists, she's a general pediatrician, I'm a family doctor, where this precision work and genomics could fit into our practice. She provides care at the Child Health Clinic at Children's Hospital Colorado, where she serves as Associate Clinic Medical Director and Medical Director of Informatics. So her work integrates informatics, quality improvement, and patient safety to enhance personalized care. With that, please help me welcome Dr. Kudron.
Thank you so much. I really appreciate the introduction. I'm super excited to be here with you today. And hopefully those on Zoom can see me. So I'm going to kind of stand in this general area. So today, as was mentioned, I'm going to give you an update on the Colorado Biobank and talk about personalized medicine at UC Health. I'm not advanced enough in my career to have any financial disclosures. So I always like to start off with learning objectives. I'm an educator at heart, so I think it's important for all of us to kind of know what I hope that you'll take away from the talk today. So in terms of our learning objectives, by the end, I hope that you'll recognize how the Biobank advances personalized medicine efforts at the University of Colorado, assess the types of genomic results being returned by the Biobank, and the unique return process that we have for each type of result that we give. Judge the clinical utility of genomic results obtained through enrollment in the Biobank versus other sources. Use evidence-based pharmacogenetic guidelines to impact drug selection and dosing, and hopefully that's something that you may have already done. And then we'll look at some clinical decision supports that are specific to UC Health's electronic health record that have been created by the Biobank. And please do feel free to interrupt me with questions. I'm happy to be interrupted. We're going to be talking about different types of results. And once we kind of move on to the next one, it is a different thing. So you're welcome to interrupt. So we're going to just start off. I did this in case format. So we'll go through 3 cases. We're going to go through an overview of the Biobank. Case 2, we'll talk about pharmacogenetic results. Case 3, we'll talk about high impact pathogenic variants. And I will define what those are, so we're all on the same page of what that means. And then we'll go through some frequently asked questions and where you can get more information. And this is the frequently asked questions, and this presentation is tailored to your group, thinking about the kinds of questions that you might be thinking from your own practice and from your patients. So I'm gonna try to keep this interactive. You can do this part on Zoom as well. So what is one word that you associate with personalized or precision medicine? So you can pull out your phone, you can get the QR code, you can go either online or text. And our poll, we have our amazing tech help. So the poll should work. If you want to switch it so that we can actually see Yes, so well, I'm just gonna wait a minute or two to see some responses. So it's a typical word cloud. If someone sends in a word more than once, it'll appear bigger than the others. And as more and more come in, you can kind of see. So I'll tell you, I've been doing this since 2018 with a variety of audiences, from medical students to very practiced providers, or very experienced providers. And expensive is probably the number one thing that I see from every group, whether it's medical students, our trainee residents and fellows, seasoned providers. Expensive, time, technology, that comes up a lot. Depending on the group, a lot of people will put in genetics, or they'll put in genomics, which we're not seeing here. Biological comes up a lot, outcomes, luxury, that kind of goes with money, tailored, complex. So I think your group is thinking very similarly to previous groups. But what I like is that you're not thinking genetics or genomics. And I think that's a really important point to personalized and precision medicine. Is today, I'm going to really focus on the genomic aspects of precision medicine, but there are many aspects of precision medicine or personalized medicine that are not genetically related. So thanks for taking a minute to do that. We can flip back to the PowerPoint. So I will tell you that I'm going to flip back and forth between using the terms personalized and precision medicine. And depending on who you talk to on this campus, if you go to the literature, people use these terms to mean different things. On this campus, generally, many people go back and forth. And that's because the personalized medicine efforts that began in 2015. And that was around the time that President Obama announced his personalized medicine initiative. So that was the preferred term when the Colorado Center for Personalized Medicine was created. So we use the term personalized medicine here. There's now been a shift in the literature to more of a precision medicine, personalized medicine, thinking more individualized, precision medicine, thinking more genomics. So I want to point that out, that depending on who you talk to and even what campus you're on, people utilize these differently. From our perspective here at CU and with UC Health, when we're thinking personalized medicine, we're thinking holistically about all the things, all the information that you can get as a provider about your patient. So genetics, medications, tests, all the encounters, their home, what's happening in their home, what's happening in their social environment. Obviously, some of these we have on all our patients. Some of these, if you wanted to get all of them, I'd probably dare to say there's almost no patient that we have all of these at this time, integrated in a way that you can utilize it in the clinical setting when you're seeing a patient. Our main focus over the past 10 years has been integrating the genetic piece in a way that is functional, that you can utilize in the clinical setting, and bringing that together with genes, meds, tests, and encounters. Maybe a little bit home. We're not to the environment piece yet, but you'll see that, this is our researchers on campus are really thinking about how do you bring all of this together. And so we really want to bring, the ultimate goal is have sophisticated data science. That's where our informatics comes in, advanced medical research engine, and then expertise on actionable insights. Bring all this together for personalized treatments. If we have better personalized medicine, then the goal over time is you're going to have better outcomes, reduce side effects, that you're going to have patients come back and they're going to be more satisfied because they got what they wanted more quickly. So the Colorado Center for Personalized Medicine is a joint effort between the University of Colorado School of Medicine and UC Health. When it was initially founded, Children's Hospital Colorado was involved. Children's Hospital Colorado now has their own Precision Medicine Institute, and I think that's important to acknowledge. That's really tailored to the unique needs of children. So the Center for Personalized Medicine brings together people from across campus. It brings together researchers, it brings together informaticists, the pathologists, those who have expertise in genetics, with the goal that we can integrate genetics into the clinical care that is being done at UC Health to improve individual health, but also the health of populations. So we're going to go through some cases. So first case, we have a 47-year-old Caucasian female, history of obesity, hypertension, hyperlipidemia, depression. She's enrolled in the biobank. She enrolled 3 years ago. We'll talk about how you can enroll in the biobank and how your patients might have enrolled. She receives a My Health Connection message that says she has a new test result. So she goes into her My Health Connection. It's a busy morning. Her kids are running around. She sees that she has a result. She thinks it's from the biobank. She's like, okay, I don't have time to deal with this. And she goes on with her way. And then she recalls later that there was something about a gene that might impact a medication she takes. She goes back in, she can't find the result. She doesn't have a lot of experience with My Health Connection. So she sends you a message and says, oh, you're my primary care provider. You should know about this result, right? So this is obviously a real case that we've had happen. So we're going to go through, how do you answer this? So in thinking about how you get genetic information, obviously, as a clinician, you can order genetic tests. There's direct-to-consumer genetic testing, which at the time that I started in my role here in 2018 was really on the rise. And now, as you all know, there's been a significant shift in that landscape. And then there's biobanking. We're going to focus today on biobanking. We are not going to talk about provider-ordered genetic testing. We're not going to talk about direct-to-consumer testing. Those are totally separate talks. But I think it's really important to acknowledge that genetic results can come from a lot of places. And you can have patients who come to you with a test that was ordered by another provider, or they bring in their direct-to-consumer genetic test results. So first, I just want to ask how many of you are familiar with the biobank? So if you can pull up the poll everywhere, there's some options for you. So A is very familiar. You know the types of results returning, the plans to return. B is somewhat familiar. You know it exists. You know we're returning results. C is vaguely familiar. You've heard of it, but you don't really know anything about it. And D is you've never heard of it. This is the first time you've ever heard of it. I know that's not on the screen. I'm hoping very few people will be D. Maybe we can scroll down a little bit to see. Oh, we've got some Ds. That's why I'm here. I think we'll probably leave it. I don't think there's going to be a lot of, there's very few at the top generally. Okay, so it looks like we're almost split a third, a little bit less than vaguely familiar. I'd say that when I started this, obviously almost no one was familiar. And at this point, actually, family medicine is the only group that we have not had a huge presentation to, which is, our fault as well, but very important that you are aware and understand all of this because it can affect your patients. For certain groups like our hospitalists, they tend to be more familiar because this is something that they're seeing in the hospital frequently, but definitely for our more outpatient providers, often less common that they're aware of this. So we'll keep going. If we can go back. Thank you. So the Colorado Biobank, founded in 2015, we're going to go through where we are in terms of our results and patients enrolling. But this is the process, and this is the process that we show our patients and our participants. So if you're looking at this, the first thing that happens is you have to sign a consent. It is a research study. Comer oversees this study. It is the largest research study west of the Mississippi. It is very, very large. The first thing that happens is the consent is in My Health Connection. Many years ago, we had the consent on paper, then it moved into an electronic consent. It has been a My Health Connection here for over, I think now it's been 6 years. And we didn't have a lot of patients on My Health Connection when we began. Then we had the pandemic. And as most people are aware, the pandemic really accelerated people getting onto My Health Connection. So you can go into your My Health Connection patient portal as a UC Health patient. You can click on research, and this will come up. The consent comes up for anyone who's over 18 and can read and understand English. We are working on getting it in Spanish. And the current consent has key bulleted points that go over the key parts of it, and then is obviously a much longer research consent. This is also offered at e-check-in for every UC Health appointment. If someone declines, they are given 1 year where they're not asked to consent, and then it does come back again for them after 1 year. So once they've consented, we collect a blood sample. or saliva sample. The saliva samples are only for like a targeted population. Generally, it's blood. It's during their next blood draw at a UC Health facility. And so it's just an additional purple top tube that's collected whenever they have their next blood draw. This goes to our lab that is here just in the building to our right in the Anschutz Health Sciences building. They extract the DNA, and then they do some genetic testing in-house. We do have a partnership with Regeneron where they do genetic testing as well due to the volume of samples that we have. And then those are linked back to the patient. And those results can be utilized for research. So we have a very robust amount of genetic data available for research that's connected to the electronic health record, as well as results that are available to go back to patients. And then what you're most interested in is what results are we sending back to patients? So we're going to talk about the two types that we're sending back. If you are interested in the research, I'm happy to talk about that, but that's not the focus of our talk today. So in terms of our enrollment and who we actually have in the biobank, as of end of last month, we had over 274,000 participants. I'll show you a heat map of where they all come from. We had over 161,000 samples collected. You can see there's a big drop between those who are consented and those samples that are collected. And that is mainly because, as you're aware, patients go and get labs outside the UC Health system, or they consent and then they don't have another encounter in UC Health. And then once a sample is collected, we have the ability to return results to participants 100% for free. So the participant does not pay anything to receive those results. And we just hit over 100,000 participants with results returned. We are the 4th largest academic biobank in the nation, and we are the nation leading. We can't actually quantify, but we believe probably the world leading pharmacogenomic return of results program. And I will say now, because people are always thinking, well, those are research results. These are clinically actionable results, which is what's very, very unique about our program. So in terms of demographics, you can see the heat map here. This is an older heat map. Obviously, it really shows UC Health's catchment area. So mainly participants and patients from the Front Range. It does go outside. We actually, because of the mobility of the population in Colorado, we do return results to participants all the way on the East Coast. Sometimes people are out of the country, but they have lived here at some point. We have a predominantly female population, and that is true among biobanks around the world. No one really knows why, but females tend to sign up for these type of research studies more than men. We have a predominantly Caucasian, 85% Caucasian population. We hypothesize this is for two reasons. One, we have a more predominantly Caucasian population in our UC Health catchment, but also there is some historical transgressions against certain populations when it comes to genetic testing. And we are very aware of that and trying to increase our diversity. And then in terms of age distribution, I always find it, I'm going to try to laser in. I don't know if I can do it. Well, I always find it super interesting that our biggest age group is ages 30 to 49. And we have a nice age distribution, but kind of a younger swing, which is actually pretty exciting because genetic results tend to have the bigger impact if you can catch them before someone has a significant disease or has encountered a medication where they have a significant side effect. So we're going to go through the different types of results that we're returning. High impact pathogenic results are kind of what you think of when you think of a BRCA mutation or a mutation associated with a hypertrophic cardiomyopathy. I'll talk about those in depth. These are returned with a genetic counselor. And then we have pharmacogenetic results. These are genetic results that impact drug metabolism and dosing and drug transport. And these are directly returned to the electronic health record and My Health Connection. So we're going to start off and we're going to talk about pharmacogenetic results. These types of results, we only return results that have significant evidence, that have already been vetted by the Clinical Pharmacogenomics Implementation Consortium, which is a national consortium in the United States that has evaluated the evidence for the return of these types of results. And we also do it with key stakeholders involved. So we get the specialists and stakeholders that need to be involved during the return. So these go to immediately to the electronic health record. And then a patient receives that result notification via My Health Connection. So that's what, in this case, what our patient received. you probably, as the clinician, won't know. You would only know if the patient reaches out to you, or at the time of prescribing, you see a warning. And that is the goal really here, is that we are doing preemptive return so that when you prescribe a relevant medication, you see the appropriate warning. And then we have drug-specific tip sheets as well. If you wanted to see if a patient had results, you can go to results, chart review, results and labs, or go to results review. It's under PGX Biobank. This is only for the PGX types of results. You can type in PGX, you can type in Biobank. We've tried to get it in a more functional format where you could see all these details of each gene like listed out, but unfortunately that's just not, that's very, very complex to do. So it's a report. The report has every gene, the specific variants, and the interpretation. The key thing for you to know is you don't really necessarily have to read this, because we've put this in a much friendlier format into the electronic health record. So in UC Health's EHR, there's genomic indicators. This genomic indicators tab is actually built into most Epics. So if you're outside UC Health, like at Children's, they also have a genomic indicators tab. It does look slightly different. So you can go to genomic indicators. It's at the top. So you can, it should automatically be there. And then it'll pull in all of the relevant genomic indicators related to pharmacogenomics. And then you can see, I don't think I have a highlighter. You can see that it has the gene overview, then it has all the medications listed, and then those are all clickable links if you wanted to read more information. So what does this look like? That's for you as the provider. What does this look like for your patient? Or many of our providers are actually enrolled in the biobank. So this is the type of message they receive. It says, greetings, obviously a fake name. You have a new test result from the biobank at the Center for Personalized Medicine. They can sign into their account. They can also get push notifications. And then it'll show their biobank results, and that'll sit at the top of the page for 14 days. So it should be fairly easy to see. We've recently added this past summer. So this is, if they clicked into the report, a new area where, oh wait, how do I go backwards? We've recently added a new genomic indicators where it doesn't have all of this information, but it has the key information in a much more digestible format. Clearly, this is written with all of the key information that has to be in there from a legal perspective, but we have this in a more digestible format now for patients on their My Health Connection. And then this is kind of what that consenting process I mentioned looked like. That's an e-check-in, and then it guides them to look at the consent. You can go to research opportunities, and it sits there for anyone who's ever encountered UC Health. It's in there, and then people can see if they signed up or not. So in terms of this case, hopefully this was helpful to kind of see what it looks like for you, what it looks like for your patients. We do have universal dot freezes built in. Everything PGX is .pgx. And it should be available to you. Please let me know if it's not, because we have opened these up to every provider in UC Health's EHR. And this is, if you pulled up that dot phrase, this is what you would be able to send to your patient already written out for you. And it says, I've noticed that there was new genetic test results. These should be at the top of your UC Health Connection patient portal. And then the other key thing to note, and I should have pointed it out earlier, is that the results file under the date the original biobank sample was collected. That's because today, if you order a CBC and your patient gets it 2 weeks from now, that's going to file on the date it was ordered, which is standard for all lab tests. So we can't change that. Someone might have consented and that test was ordered the day they consented, and then 2 years later they get it, or even a year later, then they get results. So that's a key point for you to know and your patient to know. And then it has more information. Did I see a question? Okay. So we're going to go into another case. So we have a 50-year-old Hispanic male with a history of hypertension, hyperlipidemia, tobacco use, and depression, who presents for follow-up of dyspepsia. He has positive H. pylori testing, and you want to treat him. So you're going to treat him with clarithromycin, amoxicillin, and pantoprazole. He's enrolled in the Colorado Biobank. You may or may not be aware of that. And he's received pharmacogenomic results. So he's a CYP2C19 ultra rapid metabolizer. And then you go to prescribe the pantoprazole. You don't need to be aware of that he's had results. You don't need to be aware that he has this phenotype, and this is the warning that you see. So you put in for pantoprazole, and you can see there's multiple different aspects. So this is what's called an inline medication warning. It's not a pop-up in your face that you have to acknowledge. It simply gives you additional information. So it says patient may have an increased risk of treatment failure for H. pylori eradication or erosive esophagitis. And then we do link to a tip sheet. There's multiple places it links. You can click see more or pharmacogenetic guidance. So you could ignore that. You could click on additional information. So you could see what to do. You could decide, I see this, I don't need more information, I'm just going to prescribe something else. This is what our tip sheets look like if you click on them. So this is particular to this patient. So this is for CYP2C19 ultra rapid metabolizers. You can see it's telling you that the recommendation is to use esomeprazole or I never prescribed this one, so I can't even say it, rabeprazole. And that this patient likely will have treatment failure on pantoprazole because of their CYP2C19 ultra rapid metabolizer status. So I will ask in a few minutes how many of you have actually seen warnings. This is all of the medications that we currently have warnings built into the UC Health electronic health record. The key thing to note is that these will only fire for biobank pharmacogenomic results. Because of the way direct-to-consumer or provider-ordered pharmacogenetic testing goes in, it goes into the media tab. You can't build clinical decision support off something on the media tab. We do hope in future years that we'll be able to build clinical decision support. If you ordered pharmacogenomic testing, we got into the electronic health record in the right way, we could have similar warnings. Right now we don't. So this is only for biobank participants who have results returned. So for 12 genes, we have warnings for 55 medications. I'm not going to go through all of them. I'd say the biggest groups is the PPIs, SSRIs, the statins. Then we have thiopurines, a lot of medications impacted for our oncology group. Tacrolimus is only for new starts, inpatient only, so probably something you wouldn't see. And warfarin's actually turned off right now, but for new starts, we're reevaluating the warfarin, but we'll be turning back on. There's other common ones like ondansetron, codeine, sometimes people still use atomoxetine, and then a lot of the tricyclic antidepressants and the antipsychotics. So you can see that for some of our providers on campus, they could potentially be running into these warnings every single day based on what they prescribe. For others, you might not prescribe a lot of these medications that frequently. Clopidogrel and voriconazole are also interruptives. So interruptives in your face, you have to acknowledge it. And we chose these based on the fact that there's much more significant side effects for someone with genetics, certain genetics related to those medications. 95% of our warnings just give you additional information. Some examples. So for the thiopurines, these can lead to severe, potentially life-threatening decreases in white blood cells for patients with certain genetics. For the NSAIDs, including ibuprofen, there's increased blood pressure, decreased kidney function, and GI side effects. So that's another big group. The rosuvastatin is probably the only other one that you're commonly prescribing that can lead to muscle pain and weakness, which you've probably heard from some of your patients as a side effect. There are genetics connected to that. So I'm just going to ask how many, if you've encountered a pharmacogenomic warning in UC Health EHR, and if we can go back to the poll everywhere, this is another multiple choice question. Can you connect us back, please? Thank you. All right, we'll go to the next one. So A is you've seen lots of warnings. B is you've seen one warning. C is you haven't seen one. And D is I don't remember, which is always possible with warnings because there's so many in the electronic health record. So we're almost split between those who've seen many and those who've not seen one at all. Which is actually interesting to me. Probably thinking that if once your patient has pharmacogenetic results, you might be prescribing more medications that are impacted. All right, we will go back to the presentation. So in terms of our pharmacogenetic results, we've returned, as of earlier this month, over 1 million pharmacogenetic results. The key thing to remember here is that one patient is going to get all of those 12 genes. So that doesn't mean that 1 million patients have results returned. So we have, we're about to hit the 100,000 mark for participants with results returned, which is, I'll show you kind of when this all started. We're very happy that we've been able to return so many results that can have a significant impact. And then we've had 26,000 drug gene alerts in practice. So a fair amount of drug gene alerts. You can see that the most common are the PPIs, which is why I wanted to show you that one. Next most common is statins, SSRIs, NSAIDs, and codeine and tramadol. And that is why we do always encourage providers to actually prescribe your ibuprofen to see if the warning does come up, or to ask your patient if they're taking it, and then go see if there's relevant genetics. In terms of our growth, we really only started returning pharmacogenomic results at the end of 2021. So since that time, we've had exponential growth. We continue to expect to have exponential growth. Obviously, there will be a point where we may hit a time when we've sort of capped out who would want to enroll in a study like this at a large academic hospital. However, UC Health does have new patients coming constantly in and out. So, you know, we'll have to see if and when that does happen. We still have many patients who are enrolled in the study. They haven't had a sample collected yet. So if you haven't had a sample collected, you're not yet eligible to receive these results. So this continues to go up. And then in terms of thinking about impact, so 90% of our participants have at least one polymorphic PGX phenotype. Really, what that means is that 9 in 10 patients have something that is going to have an impact on their medication. So studies have shown that when you do pharmacogenomic testing on large populations, almost 100% of people will have some genetic variant that could impact prescribing. You just have to get high enough numbers. And I should have said 99%, not 90%. It used to be 90 a year ago, and now it's up to 99. And then 51% of participants have at least 4 polymorphic phenotypes. Really what that means is that they have 4 significant phenotypes that could impact prescribing. So you can see how this can really impact your clinical care. In terms of our interruptive alerts, we've had 100% of participants that had a high risk warning. The right thing was done at the end of the day. So 100% of the time, that warning avoided a patient receiving a medication that could have had significant morbidity or mortality related to it. Greater than 30% of the clinical actions that occur are on high-risk meds. And we recognize that. We recognize that most of the time, people are not prescribing PPIs for H. pylori or erosive esophagitis, and you just move on. Or your patient has done very well on Celexa in the past. And so you're going to move on past that warning because that patient, you know that they've done well. So that's why this is additional information, but not necessarily, doesn't always change prescribing. We have dot phrases, as I mentioned, built out for all of these medications. So if you type in .pgx, .pgx PPI, .pgx, this is for brivaracetam, .pgx voriconazole, there's information that we hope as a PCP you would be receiving from the hospital if this is seen. And then there's information that you can give your patient, and it has all of our contact information. We recognize that providers are not going to be experts on this. So in conclusion of this case, the provider sees the warning, they click on the tip sheet, they decide to prescribe esomeprazole, and then they use the .pgx PPI to patient in the after visit summary to help them explain why they made that change. Are there any questions related to pharmacogenomics before I move on to discuss our next type of results? Yes. Oh.
Is it only patients that have gotten care at our hospital here? Like, you know, there's 15 hospitals for UCH.
So it is not this local hospital. So because the EPIC instance crosses all of UC Health. So it's any UC Health facility that has UC Health's electronic health record, which is all those hospitals you mentioned. Okay. The only exception to that is some of the UCHMG small clinics have a different EPIC instance. Oh. But that's very rare. So it does go across the region. And we do presentations north, south, all over the state. Okay, in the interest of time, I'm going to keep going. So we have a 30-year-old Black female with a family history of father, and I'll tell you, this is a real case from family medicine, with father diagnosed with colorectal cancer at age 42. Unclear if there was a genetic cause of the father's colorectal cancer, so you decide to order a colonoscopy. 2 weeks before the colonoscopy, this patient receives a call from our genetic counselor with the Biobank, and she receives a positive result for an MSH6 variant, which is associated with increased risk for Lynch syndrome. So we're going to talk about high impact pathogenic variants and what that means. Sometimes people call these secondary findings. Sometimes people call them incidental findings. We always return these with a genetic counselor. They never go directly to the My Health Connection patient portal. So these are, we didn't make up the genes we're returning. So these are defined by the American College of Medical Genetics and Genomics, or the ACMG. Since 2013, they've published guidelines for, if you're doing genetic testing, you should be looking to see if a patient has these results, and if they are positive, they should be returned. And the reason for that is that they are clinically actionable. That means we can do something to prevent morbidity and mortality. And I'll go through what's in those genes and what's not. You can see they've updated the list. So since the most recent update in 2023, there were 81 variants related to 43 genetic diseases. These span a range from hereditary cancers and cardiovascular disease to inborn errors of metabolism, and there's sort of some miscellaneous genes. And most are hereditary cancers and cardiovascular disease. So hypertrophic cardiomyopathy, arrhythmia syndromes. And then the 9 genes is kind of random, mainly more things that we would see in childhood. One of them is MODY. And then you can see what we do. So if you had a positive variant, then you can do additional disease screening. We have had many patients who've received a cardiovascular variant, never seen a cardiologist, never had exercise intolerance or syncope or chest pain, and now they're undergoing an echocardiogram. They're seeing a cardiologist. They're talking about their exercise regimen, and we can really have significant prevention of morbidity. The key part, I already mentioned, these are clinical grade results. So our results all go through additional testing called Sanger sequencing to make sure that these are actual real results. This is very different. If you think of the All of Us research study, which is the NIH-funded large biobank, they return research results. They do not return clinically actionable results. There are almost no research studies in genomics because we have to go through additional testing to confirm that these results are actually viable and can be utilized in the clinical setting, so you don't have to repeat them. So that's a common question we get asked. Do I have to repeat this? It's a research result. It's from a research study. These are clinically actionable and should impact care immediately. And this is the process we go through. So there's that additional sequencing from when they go out to Regeneron or they're sequenced here. Then we do confirmation in our CLIA certified CAP accredited laboratories. It has to be done in a very specific laboratory setting. We confirm we have a clinical grade result. Then our genetic counselors reach out to the participant. They call them as well as send them a message in My Health Connection saying you have a result. Would you like to receive that result? They confirm their desire to receive the result. So they can say, you know what, I don't want to receive this result. We'll talk about why they might not want to receive it. Once they have then spoken to the genetic counselor, so they have I want to receive the result, then they set up a separate phone call to talk about the result at the right time for them. Then they talk to a genetic counselor. This is not a full genetic counseling session. It's a return of a result. And then they can help get them connected to the right specialist. Many of our patients just say, I want to go talk to my PCP. And then this is when the result goes into the electronic health record. After that conversation has occurred, they've confirmed they want to receive results. And then they are encouraged to follow up. And we are evaluating how many of these patients do follow up and with whom. So we just hit the 1,000 mark for these results. We were very excited. Doesn't sound like a lot compared to the 100,000 pharmacogenomic results, but as I know you're all familiar, some of these can have really significant impacts on people's lives. And it's a lot of effort for our genetic counselors to go through and return all these results. So as of March last year, or March this year, we had 1,390 results that were available to be returned. And then we had 846 that were reported, and then we had some that were pending. Now, the key part here is that we have about 20% that we get no response from them. So the result is not reported out. We make multiple attempts. If they don't reach back out, we don't give them that result. And then we've had 5% of people withdraw. And a common reason for this is they feel like they don't want, at this point, they don't want to receive something like that. They're not at the right time for them. There's sometimes a delay as well where people want to go get life insurance, or they want to go get disability insurance because there are implications on someone's ability to do those things after they've received these results. So other things that have happened in terms of the withdrawal is that we've had individuals in the military that have withdrawn due to privacy concerns. The Genetic Information Non-Discrimination Act protects against discrimination from genetic results in health insurance and employment, does not protect against discrimination in life insurance, disability insurance, and it does not apply to people in the military. So they're of a unique group. And then some people withdraw because they're just not interested. And then we have had individuals who are diagnosed with dementia since signing the biobank result. We are not allowed to give those results. So that's just one of the reasons, some of the reasons that people don't want to receive them. And then these are what we've actually returned. So we anticipate if we did a huge population study, 2% of the population will be positive for these types of results. And there's really good literature to show it's about 2%. The majority of them in the gray bar are cancer-related genetic results. Then you can see the orange group is the cardiac-related. Familial hypercholesterolemia is a very common one that's in the greens, the larger green zone. And then we have amyloidosis in the blue and malignant hyperthermia in the purple. And obviously you can think that malignant hyperthermia is one that can have very, very significant impacts on someone before they undergo anesthesia. And then we have a large group of others. In terms of surveys of our participants, 67% received the reviewed the result with their PCP. So over 2/3, 30% have reviewed it with a specialist. And this was as of 1 year ago. We sent out a survey and asked everyone who'd received results. A little over half had completed medical tests related to it. 92% reported no problems getting their medical tests completed. 88% reported problems getting medical tests completed based on, so this is where there's discrepancy. They reported issues, including insurance and time, to both meet with the provider and to get the tests completed. But they were actually able to do it. And then 88% reported no problems paying for care related to the result. Obviously, that's something that always gets asked. We really stop. All of this has been free, and now you have this result, and we're telling you to go get testing, and we don't have control over what insurance does and does not cover. So in this case, this was a real case. This patient had her colonoscopy, was totally normal. She went and saw Dr. Swati Patel, which is a Lynch syndrome specialist. She's a Lynch syndrome specialist here at UC Health. And she recommended, and I apologize for the typo, colonoscopy with ileoscopy every 1 to 2 years, upper endoscopy and H. pylori testing now for this 30-year-old. And obviously that's not something that we would typically be doing for someone who's asymptomatic. Considering daily aspirin after discussion with the PCP, multiple of these pieces involve the PCP, annual dermatologic exam, more starch in the diet, and then gynecologic screening. And the gynecologic screening for Lynch syndrome is quite extensive. So she will now have a lot more screening, but hopefully can have detection of a malignancy much sooner. I just want to get to some frequently asked questions and then open it up for full conversation and questions. So a question that we really commonly get asked is, I have pharmacogenetic results in my EPIC in basket. What should I do with these? Hopefully that has not happened to you. You shouldn't be getting them. But if you are getting them, there's really no action necessary because they've already received those results through My Health Connection. And anytime that this would have clinical significance, as long as you're in the UC Health EHR, there's clinical decision support in the electronic health record. Another one is, I have a patient in my clinic who can't afford genetic testing, or you don't think it's going to be covered by insurance. Can I get them enrolled in the biobank? Or can I look at their biobank data to see if there's a mutation? And unfortunately, we can't do that. And the reason is that our biobank genetic testing is not comprehensive. So let's say you want to order BRCA testing for your patient. We aren't looking at all of the things that someone who has a family history of breast cancer. We're looking at very specific aspects of BRCA, but there's much more in a gene panel for breast cancer than all the things that we're looking at. And so it's not the biobank testing is not a substitute for targeted genetic testing. And there's a significant lag time between signing up, getting the sample, and receiving results. So it's taken us multiple years to get to a point where people are getting that a little bit more quickly, but it can still take months to even a year for that to happen. So if you think a patient warrants genetic testing, the biobank is not a substitute. The other key thing to know is that the patient already has had biobank testing returned. That is not a substitute as well. So that's the other question we receive. I have a patient who received genetic test results from the biobank. After review of their family history, I think they need genetic testing, in this case for breast cancer syndromes. So they already had biobank results returned, right? So that should be fine. I don't need to order the genetic testing. We encourage everyone, if you think a patient warrants genetic testing, they should have that genetic testing for that particular syndrome done. And I know I'm saying that more than once, but I think it's a very important point because there's going to be things that are tested on a targeted panel that we didn't do. This is almost my last slide. So biobank genetic test results are clinical results. They can be used immediately in clinical decision-making. You don't have to repeat them. You don't need to do any additional testing at that time to confirm what you're seeing. We talked about the different types of genomic results and how they have different return processes. And then the biggest role for primary care is encouraging your patient to seek appropriate follow-up because often this is pretty intimidating to get a result like these, and these patients do need that appropriate follow-up care. And often it has family impacts. So you might be someone who's taking care of a whole family and only one person received that genetic result. As you know, that can have pretty wide extending impacts on additional genetic counseling and genetic testing for those in the family. If you are interested in telling patients how to enroll, we have a very cute video on UC Health. There's lots of information on UC Health. That's where participants who are interested in enrolling, or if you were interested in enrolling, you should go to the UC Health page. Once participants are enrolled, or if you are looking at information as a research investigator or as a clinician for your patients, we then transition people to go to the CU Anschutz page. And the CU Anschutz page has a specific area for providers. This is written at provider level literacy, has all of this information that I presented to you. We have a return of results section just to the left. That is for patients, and that is written at a patient level literacy, and all of that goes through our UC Health literacy team. There's a huge group of people that work on this project, as you can only imagine. Casey Green is our no longer interim director, permanent director, and biobank PI. David Kao is our medical director. Christina Aguilante runs our pharmacogenomics program. Emily Hurst and Anna Tanaka run our UC Health operations. Christy Cook runs our genomics laboratory. And then we have many others, including our patient engagement team, our genetic counselors, and then I do program education. So you are always welcome to reach out. If you are interested in learning more about personalized and precision medicine, we do have a membership program for the CU Anschutz campus. We have seminars and speakers. We have a retreat every year. And for some people, they really enjoy learning more than we just talked about today. And I'll thank you so much and take questions.
Thanks for talking. You probably answered this and I missed it, but if you go back to that colonoscopy case.
Yeah.
Was she screened because she'd already signed up for Biobank? And so whenever we order a colonoscopy, if somebody signed up for Biobank, that test gets run? Or was it because she's younger than the usual screening age, or how did it happen?
How did she receive the colonoscopy?
How did you know to check her for Lynch syndrome?
So that's a great question. Every participant in the biobank receives testing for those. So there's the American College of Medical Genetics and Genomics genes in here. There's a whole group in the hereditary cancers that are related to Lynch syndrome. All of the genes that are on this list, those 28, we screen patients for. So she just happened to enroll in the biobank and get screened. It was the timing of her father having the colorectal cancer diagnosis, her getting the colonoscopy was just luck. So every patient enrolled in the biobank does have some Lynch syndrome screening. And some breast cancer screening as well. But it's not, as I said, it's not everything that you would get in a targeted genetic test.
Does this expand over time? And when it does it run on the banked samples?
So it does expand over time. So they've expanded it. We're founded in 2015. We actually started really doing our testing in the late 20-teens and early 2020s. And so we were testing on the 78. We now test on these 81. We do not, once you've been tested, we do not test you again. So that's the other reason that targeted testing is really recommended as this continues to expand. And that's simply based on resources. We are doing this, we call it for free, but this is a program that UC Health and the university have put millions of dollars into providing this for free, partially so that they can advance genomic research. We have lots of people across campus utilizing this for research, but also so that we can advance personalized and precision medicine for our patient population in Colorado. But we do not, once you've been run, you do not get run again.
If the pharmacogenetic testing says that a patient should be on a medicine that isn't formulary, will that be accepted by an insurance company for prior approval?
That's a great question. We have not had any issues with, as long as the provider utilizes the language that we have in our tip sheets that says this patient has this genetics, therefore this medication is not recommended. We have had no issues, particularly with like the more extensive morbidity and mortality medications. So let me go back. Where was it? Oh, it's way back here. For this group, the interruptive warnings, we have had no issues. For particularly clopidogrel is a lot cheaper than the alternatives. And that was the very first drug that we ever did back in 2017, 2018. And since then, that is something that we've cataloged, and insurance companies recognize this is happening more and more, and we'll cover it. And please let us know if that's an issue you run into. That's something our team wants to know.
Okay, so we do have a question online. If a patient is in the biobank and the results for those genes are negative, would they find out? Or does someone at UC Health only reach out to patients when they test positive for those disease-associated genes?
Great question. So for pharmacogenomics, everyone who enrolls receives pharmacogenomic results. So you would receive information that you're a normal metabolizer, because that has pretty significant implications. And that's a different type of genetic testing that's done. For someone who's negative, let's say for BRCA, we do not give that result because they don't go through clinical confirmation testing. So only someone who the first round of testing says, oh, you probably have a positive variant, then they go through clinical confirmation. So anyone who that initial round for a high impact pathogenic variant, if that initial round of testing is negative, they do not receive a negative result because we know that there could be false negatives. Thank you so much. And I'll stick around if anybody has any additional questions.
Thank you so much for being here today. We're so grateful. This was a very informative presentation, and we'll make sure to put the slides on our intranet so that we can share them with everyone. As a reminder, online, you have the link for our survey, and in the room, you can just scan the QR code. Thank you so much for being here. We hope to see you next week for the Levitt as well. Make sure to register for that because the last day to do it in person is tomorrow. So thank you very much. Have a great day.